people, to whom I wish to pay my respects to elders past and present. Just to note too that Monash University is observing a week of silence as requested by First Nations people following the results of the referendum. So welcome to you all. I'm speaking to you from a very beautiful sunny day in Melbourne. And so we would love to know where you are from. If you feel inclined, pop into the Q&A where you're from and maybe tell us about your weather there as well. So we have the great pleasure of having three fantastic experts in this field, whom I will introduce in just a moment. Just to note that the information provided today is relevant to biological females. And so if there are those among us here today who do identify as a woman and have had gender-affirming hormone therapy, by all means, add your questions into the Q&A and we will provide written responses later on, as we will provide to all the questions, in fact. So we will welcome today the fantastic Associate Professor Amanda Vincent, Dr. Esther Davis, and Dr. Samantha Kozica-Olenski. And the format for this hour will be that our three experts will briefly present, and then we will go straight into Q&A. So please feel free to pop any questions you may have into the Q&A box, and I will keep an eye on that. So without further ado, I will start the slideshow and we will get going. So if people can confirm that you can see that, okay. Yeah, all good. All right, so I will just go back here. So we will start with Associate Professor Amanda Vincent. And Amanda, if you could just briefly introduce yourself and then go ahead.
Great. Thank you very much, Rhonda. So my name is Amanda Vincent and I lead menopause research at MCHRI, but I also am one of the endocrinologists in the Monash Health menopause clinics where I've worked for the last 20 years. And I'm also past president of the Australasian Menopause Society. Rhonda, if I can have my next slide, please. So this diagram just shows you what the life course is in regards to menstrual periods. So your first period is, the medical term is menarche, and that usually occurs between the age of 11 to 13. And then you then have a time where the menstrual periods are usually regular, and that's when most people would have their children, their pregnancies, until you reach the time of the menopause transition, which occurs around the age of 45 to 47. And this is the time leading up to the menopause. The key feature of the menopause transition is a change in your pattern of menstrual periods. They often become less frequent and they become irregular. Menopause is the no. Go back, please, Rhonda.
Sorry, I preempted you. Go ahead.
Menopause is the final menstrual period, and that occurs in Australia at the usual age of around 50 to 51, and that is followed by the postmenopause phase, which is the rest of your life. Now, if both ovaries are surgically removed, then that will cause menopause at any age. 12% of women experience early menopause, which is where menopause occurs between the ages of 40 and 45. And 4% of women will experience a premature menopause or premature ovarian insufficiency, which occurs before the age of 40 years. Next slide, thanks, Rhonda. So what happens at menopause? Well, at birth, your ovaries contain the highest number of egg cells, and these progressively decrease throughout life, with a more rapid decrease after about the age of 35 years. During the menopause transition, as there are less and less egg cells remaining, you get a decrease in your estrogen levels, your periods stop, your menopausal symptoms start, And there are body changes which occur which can increase your risk of heart disease. Next slide, please, Rhonda. So this slide just shows you some of the changes that occur with menopause that can affect your risk of heart disease. So if we look at the top panel, around the menopause transition and menopause, you have the onset of hot flushes. And those people with more severe hot flushes, that is associated with a higher heart disease risk. Women will also experience a gain in fat mass, particularly fat around the middle or abdominal adiposity. And this can influence the body's metabolic system and also their heart disease risk. Women can experience an increase in blood pressure. They can have changes in their blood fats or cholesterol, which makes them more prone to develop narrowing of the arteries. And changes in the handling of the body with insulin and blood sugar can occur, which increases your risk potentially of diabetes and pre-diabetes. If we look at the lower panel, women can experience disrupted sleep, which can occur by the menopause itself or also be due to the hot flushes. They have changes in blood vessel health, so that the arteries become less elastic and stiffer. We have decrease in muscle mass, which can again affect metabolism and particularly that insulin resistance that I spoke about before. There are changes in energy metabolism, which makes it more prone for weight gain. And also there are changes in heart function itself. These changes are also seen in those women with early menopause or premature menopause, and they have an even higher risk of heart disease than women with menopause occurring at the natural age. So if we look at this in summary, menopause combined with the changes that we see that are associated with aging, which also can result in, for example, decrease in your muscle mass, changes in weight and fat mass, plus heart disease risk factors, which we're going to hear a little bit more from Esther, all of these factors can increase your heart disease risk. So it's important to realize that menopause is a time when we should think about what our heart disease risk is and also how we can prevent heart disease in later life. And the next two speakers will, talk a little bit more about both of these things. So thank you for your attention.
Okay, so Esther, over to you.
Thank you, Rhonda, and thank you, Amanda, for the opportunity to speak. I'm Esther Davis. I'm a cardiologist at the Victorian Heart Hospital, where I work with a specific interest in women's cardiovascular health. And I'm also work with the Victorian Heart Institute, looking into how we can work together towards research to reduce heart disease in women. Next slide, please, Rhonda. So heart disease, and I think you might have 3 or 4 clicks here because I'll just skip through, apologies for the animation, is a very broad term, and there's lots of things that heart disease can be. So what I'm mostly talking about today, and if you can just advance the slide for me, Rhonda, is coronary heart disease, which is where fatty material, plaque, builds up in the arteries to the heart muscle. But you can also have issues caused by abnormal heart rhythms, heart failure, where the heart doesn't pump strongly or normally. And finally, I think one more progression there is valve disease, where there's problems with one of the 4 valves that keep blood flowing in the right direction. So heart disease actually sort of constitutes quite a lot of things. And heart disease is really common in Australian women. If you look here, there's the second cause of death, coronary artery disease, so that plaque build-up. And if you actually include all of the other types of heart disease I just spoke about, heart disease is overall the #1 killer of Australian women. And women have less heart disease at a young age, but within about 10 years of menopause, they catch up very rapidly to men. And women do tend to have poorer outcomes of their heart disease when compared to men. And there are a lot of aspects of heart disease. It's not completely preventable, but there are lots of things we can do to prevent or reduce your risk. And overall, about 20 Australian women die every day from cardiovascular disease. So it is a big problem. If we move on to the next slide. So in brief, there are a lot of risk factors for heart disease, and I sort of like to think of them as things you can't control, health conditions that increase your risk, and lifestyle factors. So if we progress, starting with things that you can't control, family history, age, we can't stop ourselves from getting older, and women may have some specific risk factors, often related to pregnancy and menopause, that are not within their control but can change their risk. If we continue on, lifestyle factors such as smoking, unhealthy diet, unhealthy weight, and physical inactivity are important risk factors for heart disease. And then finally, health conditions like high blood pressure, cholesterol, diabetes, polycystic ovarian syndrome, some cancers and their treatments, and inflammatory conditions are all important when you're thinking about someone's overall risk for heart disease. But there are some bits about heart disease that are different for women compared to men. Women are also affected by those well-established risk factors. So high blood pressure, high cholesterol, diabetes, all of them are really, really important for women. But when we're thinking about risk for women, we have to also think, have they gone through menopause and was that early? Did they have complications in pregnancy? Did they have gestational diabetes or some preeclampsia or blood pressure problems? Did they have a baby very early? Because all of those things can influence their risk of heart disease. And chest pain is the #1 sign of a heart attack in both men and women. That is definitely true. But women may experience some other less classic signs more commonly than men, things like indigestion, shortness of breath, jaw or shoulder or back pain, nausea or vomiting, dizziness, fatigue or tiredness. So they might not be quite so classic. Moving on. And it's never too early or too late to do something to reduce your risk of having a heart attack. So small changes can make big influences. Eating in a heart healthy way, regular physical activity, maintaining a healthy weight, and then working with your doctors to manage blood pressure, sugar and cholesterol can reduce your risk quite dramatically. And I think menopause is a time where women, can take a reset and think a bit about, what else they can do to improve their health in this way. And so the last thing I'd say, moving on to the next slide, is that I would encourage all women around the time of menopause to know their numbers in terms of their heart health, and to think about cardiac health and heart health as something that's as important as mammograms or pap smears when they were younger in terms of preventative health. So women over the age of 45 and Aboriginal and Torres Strait Islander women over 30 are eligible to go see their GP for a heart health check, where there's an opportunity for a review of their cardiac risk factors, and a physical examination and discussion of what risk factors exist and how we might be best able to modify them. So I would encourage all women listening, but particularly those who are going around the time of menopausal transition, to see their GP for a heart health check. And sorry, I think if you can advance through those things, I've already spoken to them.
Thank you very much. Okay, Sam, over to you.
Thank you. Am I on? Hello, thank you. Thanks, Esther. Thanks, Amanda and Rhonda. So to start off with, I'm just going to talk a little bit about lifestyle, weight, and how it impacts the impacts on menopause. So weight and menopause, as we've heard from the previous speakers, unfortunately, menopause is a time when a lot of women, when weight gain is common. Weight gain occurs for a number of reasons. It's due to aging, menopausal symptoms, reduced energy expenditure, reduced energy efficiency, and also hormone changes. But there is some good news. Oh, sorry, Rhonda, one slide back. There is some good news. While weight gain is common, it actually can be prevented. In a recent study conducted in Australia, the study results found that 60% of women in the menopause transition were able to prevent weight gain. And this was by using small, simple strategies like reducing their intake of fat and sugar, reducing their total energy intake, and exercising more, which enabled them to maintain their weight during menopause. And as the previous speakers have mentioned, I think the best advice as a dietitian that I can give is that menopause is a time to reset and to think of it as an opportunity to take control of your health and your eating and your exercise habits. So often as a dietitian, we get asked, what is the best approach for menopause, or what is the best approach for weight loss? Unfortunately, there isn't a one-size dietary approach for everyone, but the ideal diet for menopause is one that is sustainable and flexible. So something that you can actually keep to rather than setting unrealistic goals. It's something that supports your heart health. It prevents weight gain it supports weight gain prevention, and it supports bone health as well. So in terms of looking at specific nutrition recommendations include reducing the total amount of food consumed, reducing saturated fat and sugar intake, ensuring adequate protein intake, adequate calcium intake, following a Mediterranean diet, which I'll explain what that is in a moment, as well as keeping up with regular exercise. Dietary fat and cardiovascular disease. In this slide, we can see that there's different types of fat affect our body differently. Some fats are better for our heart than others. So the better sources of fat for our heart are peanut butter, almonds, cashews, hazelnuts, pistachios, and olive oil and avocados. Then we also encourage the intake of polyunsaturated fats, which is the fish group. So oily fish such as salmon, kippers, mackerel, and also some in smaller amounts, some nuts like walnuts, pine nuts, and sesame seeds. These have a healthy type of fat that supply omega-3 and omega-6, and these support anti-inflammation. Then processed foods, saturated fat is the last type of fat that we find in the diet. And these include the typical kind of foods that most dietitians and most people would know that we need to limit. So things like processed fatty meats like sausages, bacon, takeaways like hamburgers and chips, full cream dairy, as well as palm oil and coconut oil. And these foods not only lead to weight gain, but these foods can increase the cholesterol in our body. The Mediterranean diet is a type of diet that has been recommended for women with menopause and across the board for all women. The Mediterranean diet is a diet followed by people that reside in the Mediterranean region, which is Italy, Spain. And a Mediterranean diet focuses on fresh, healthy foods. As you can see in this diagram, the Mediterranean diet encourages a big intake of fruit and vegetables, nuts, seeds, whole grains, legumes, beans, and fish. And it really focuses on fresh whole foods rather than processed foods. The Mediterranean diet is supportive for heart health because it exchanges saturated fat for unsaturated fats, which help support good arteries and helps reduce our cholesterol. And it's high in omega-3s, which is anti-inflammatory effects, so it can help protect our vessels. Physical activity benefits. There's many benefits for physical activity for women who are going through menopause. This includes reducing cholesterol, reducing blood pressure, increasing muscle mass, reducing risk of osteoporosis, increasing strength, and physical activity has also been shown to improve mental well-being. The Australian physical activity guidelines recommend for women to participate in either 2.5 to 5 hours of moderate physical activity per week. So this could be something that involves when you're puffing in like a brisk walk when you're puffing, golf or swimming, or alternatively vigorous activity, which would be 1.25 to 2.5 hours per week. Other ways to measure this amount of activity we do is also aiming for 10,000 steps per day.
Electronic bikes don't count, do they, Sam?
That would be good,
no.
but no, unfortunately.
What a shame. Okay. All right. So thank you very much, all of you. So we will head into the questions section now. So we have had some questions sent to us prior to today. So we'll start with those. And the first question that we have is to Esther. Esther, this person says, I've heard that heart disease can show up differently in women. I think you touched on this. So what should we look out for in terms of a heart attack in women? Or heart disease broadly? Esther, you're on mute.
Oh, sorry, a bit of background noise where I am. So the first thing I would say is that the most common symptom of a heart attack in both men and women is chest pain, or sometimes, because it's not always pain, people don't describe it as that, it's chest discomfort or chest pressure or chest heaviness. And that's certainly the same for both men and women. But there are other symptoms of a heart attack that we encourage people to be aware of. And those are things like pain in the neck or arm, or the shoulder or the back. shortness of breath, nausea and vomiting. Sometimes in women, it can be things like anxiety or tiredness or breathing trouble without any of that feeling of pressure in the chest at all. And so these non-chest pain symptoms, both women and men can experience them, but women tend to experience them at a higher rate than men. So I think it's important for women to sort of be aware that, you can have issues with your heart without having pain in the chest. And if you do get pain in the chest, it might not be what you think it is. Women will sometimes say they think they've got indigestion or something else. And what we know about women with heart disease is that we know that they tend to come to hospital or come to medical attention a bit later than men, and there's any number of reasons for that. But certainly one of the reasons that we see both in the literature and that my patients express to me is that, one, they didn't necessarily think heart disease was something women had to worry about quite so much. Two, they, didn't think heart disease could happen to them, even if, heart disease was something they needed to worry about. And three, they didn't want to inconvenience anyone. And so I would certainly encourage women, if they're having any symptoms that are concerning them, take them seriously and go get yourself checked out.
Gosh, we're our own worst enemy, aren't we? Esther, why is it bad? Why is it so important to get early treatment, to get there quickly? So, we hear of women saying, I'll just go and lie down, I'll be fine, and delay treatment. Why is it so critical to get there quickly, even if you're not sure?
Yeah, look, I think if you're having a heart attack, particularly certain types of heart attacks that we can't know until you get into hospital, there are situations where we need to get in and open up that artery if it's blocked as fast as we can, because the longer that artery is blocked for, the more damage can potentially be done to the heart muscle. And so for that reason, we certainly encourage anyone with concerns or symptoms of chest pain to present to hospital as fast as they can. The other thing I'll say there is, don't drive yourself. If you're concerned and having chest pain, we encourage people to call an ambulance. Do not drive yourself to hospital.
Fantastic. Just a question from Baranthi. Can we share the slides? Are we okay with sharing slides with after today? Amanda, you okay with that?
We're going to it's being recorded, so we'll be able to people will be able to view it later on.
Okay, no worries. And just to reiterate, we will send written responses out to those that have registered with all the questions that we have received. So the next one I think is for you, Amanda. It says, my sister had early menopause and was considering hormone therapy. Does that affect her risk for heart disease? And have there been any new studies on this?
So as I said in my talk, women with early menopause, so, before the age of 45, and particularly those who have premature menopause before the age of 40, have about a 2 to 3-fold increased risk of their heart disease, cardiovascular disease. And that's probably due to a number of different things. A lot of those body changes that I showed you before, that will occur in women who have early menopause, as well as those who are going through the menopause transition and menopause at the usual age. The good news is that if you are someone with early menopause and you are treated with estrogen replacement therapy until the usual age of menopause, then that minimizes that increased risk of heart disease. It helps to prevent heart disease. So the way I think about it is that women before the age of 45 or 50, their bodies are designed to have estrogen. It's important for lots of different aspects of health, including heart health. If for whatever reason your ovaries stop producing estrogen or you have to have them surgically removed, then when we give you estrogen replacement therapy, we're actually replacing that estrogen that your body is no longer making itself. And so it has beneficial effects on heart health, as well as other aspects of the body, including bone health as well. And the main thing is that the type of estrogen replacement needs to be individualized to the particular woman. So you need to go and have a discussion with either your GP or a specialist about your particular needs.
I wonder if women are still worried about taking estrogen and don't want to take it, what's the risk then for those women who have gone through menopause early and don't want to take hormone therapy?
So there's some women who can't take, young women who can't take estrogen therapy. So women with estrogen sensitive cancers, and the most common one would be breast cancer. And women with breast cancer, they have treatments that will affect their heart disease risk besides just going through an early menopause, which a lot of them do. The effect of chemotherapy, for example. So we need to think about that separately. But as I said, it looks like compared to, the women with age of menopause at usual age, you have about a doubling of your risk of heart disease. So that's when it's really particularly important to look at those risk factors that Esther talked about and to try and modify and manage the ones that you can do something about.
Thank you. Sam, soy is always the big question around menopause. Is it good? Is it not good? Should we do it? Should we not do it? How much should we have? And what are the better ways to take soy products?
Soy is actually very safe during menopause. Usually the best sources of soy are things like tofu, soy milk, tempeh. These are really low in calories and are high in protein, and they're a really good, when going through menopause and weight gain and redistribution can be a problem. These foods are really helpful. So a recent systematic review actually showed that there was no link to breast cancer, and if anything, there was actually, by women that were consuming soy, actually had a slight reduction in breast cancer. So I don't think these foods really need to be limited. It's more about finding ways that women can enjoy them and that they can become part of their regular diet.
Okay, fabulous. Esther, there's a question here around different screening methods for heart disease for females. Is that the case? Are there different ways to screen for heart disease for women as opposed to men?
So it's a really interesting question. Most of the screening tests that we use to sort of stratify people's risks of heart disease or, interpret people's risks of heart disease are very similar for women and men. Some of them work a little bit better in men than women or women than men, and therefore that's why we make the decisions that we do about which ones we use. But I suppose there's some really interesting work going on about whether other things can be done that, women might have in part of their routine life that might help us understand a woman's risk of heart disease or her risk. For example, one of my colleagues does some really interesting work in looking at women's mammograms and whether changes on the mammogram can actually predict a woman's risk of having heart disease, and whether those are the sort of things that we should be taking into account when screening. So I think although the tests might not be different, there are obviously things we need to take into account when we're stratifying the risk of female patients, which are different compared to men. And those are all those things about menopause, about pregnancy, about complications in pregnancy and things like that. I think the other thing I'll say, and while we're talking about menopause and HRT, is if you have concerns about heart disease and you're on HRT, or if you have concerns about heart disease and you're on contraception at a younger age, it's important to really raise and flag that with your doctors and your cardiologist if you're seeing one. Can I keep taking this? What are the risks of me taking it? What are the risks of me not taking it? So that you make sure you're getting all the information you need from that perspective.
So I don't think it's well known that those are common risk factors around, pregnancy complications. And did I hear you just say early starting of the pill? Is that what you were saying there?
No, not
Early-
that so much,
early
but early
child.
menopause, things like polycystic ovarian syndrome have all been linked to heart
Have a
disease.
child, somebody that's had a child early, were you saying also has increased risk?
That one is less clear, but having premature deliveries, so if your babies are born early or small, is associated with increased risk of heart attack. Now, we're not sure whether it's just that pregnancy is a stress test of the body, and so these women were always going to develop, problems in the future, and the pregnancy is just showing that they're a higher risk, or whether pregnancy does something to your body. But certainly thinking about these things is really important, particularly in younger women, because we know that as women get older, women with these complications often develop some of the more classical risk factors. So they have higher rates of developing hypertension and diabetes. And once they've actually got those diagnoses, those factors kind of dominate their clinical risk picture. But before they develop those diagnoses, we've got an opportunity to intervene and treat them more aggressively to stop them from getting to that point and therefore reduce their risk.
Right, fabulous. Amanda, we hear a lot about women being missed in terms of heart disease, and that maybe doctors even are a little their sense of awareness, I guess, of women's risk is lower. What should women do? Should women be more proactive in kind of pushing for their monitoring, or what do we need to do to make sure that we're not being missed in terms of our risk?
I mean, I think that's when the menopause is a really good flag, particularly for those, 80% of women will develop menopausal symptoms. They're usually going to occur during the menopause transition, which is usually in the later part of your 40s. And as Esther commented, seeing your GP around that time, you can discuss, what menopausal symptoms that you're having, but also have that heart health checkup at that time is a really good thing to do, because then that can say, oh, okay, my blood pressure's up a little bit, or my cholesterol's not, where it should be. And then you can, you and your GP can work out a plan about how to manage that and what lifestyle things you may need to talk about and change. I mean, I think that there's certain diets that have been recommended, and Sam might want to mention this about for high blood pressure, what people should do if they've got high blood pressure to try and prevent high blood pressure. So, it really is that time to, reassess things, and that flag of those hot flushes and the other menopausal symptoms, your period stopping, is a really good time point and brings it to all attention.
Can you elaborate on that point, Amanda, that you made around, that having those with more severe hot flushes are likely to have a greater risk of heart disease? Is that what you said before? And what is that connection?
So we're not entirely sure why that is occurring. This is in studies of large groups of women, particularly those in the United States, where they did a very long study over very many years, looking at women from a whole group of women, American women. And what they found was that those women who had more severe and more frequent hot flushes were a group that was more prone to develop cardiovascular disease later on in life. Now, hot flushes, the occurrence of hot flushes does involve, reaction from the blood vessels in the body. The flushing and that feeling of heat is because of blood vessels, particularly in the chest and face, dilating, and which we call vascular reactivity. So it may be that women with severe hot flushes have more vascular reactivity, and that may influence their risk of heart disease. But we don't exactly know why. We just see that that's an association.
It's all so much. That's all so much good news, isn't it? Sam, did you want to go into detail a little bit about the diet for those with high blood pressure, postmenopause related high blood pressure?
Yeah, well, as I mentioned earlier, I guess the blood pressure is linked to also to your weight. Most women after the age of from between 45 to about 55 are gaining about half a kilo per year. So an increase in weight is also linked to an increase in blood pressure. But it's again, the Heart Foundation looks at the big encouraging the literature is really showing that we're again focusing on those fats and trying to reduce saturated fat and focusing on polyunsaturated fat and monounsaturated, which can be achieved probably most easily by eating fresh foods and limiting processed foods and takeaways, which is obviously easier said than done. Midlife is often the time when some women are very busy in careers, family, but I guess it's eating fresh and eating as simple as possible, as well as exercising regularly and as much as you can. And in our, prior research studies, we've really looked at, just setting some small achievable goals. It doesn't mean, the literature is showing that, really maintaining a strict fad diet ongoing is virtually impossible, but something like the Mediterranean diet and just small changes to your diet can be achievable. And these are the things that are actually going to have a better effect on your heart health if you can maintain a small change for a lengthier period of time, that it still has a positive impact no matter how small, even if it's just a packet less of chips a day, or reducing soft drink, or cooking a fresh meal instead of having processed food. So it doesn't have to be doing everything at once, but setting a small realistic goal.
Now, Sam, before you were talking about limiting full dairy products, full cream milk and cheese and so on. And I think that the messaging is a bit confusing because we are told we need calcium postmenopause. We're also told that full cream milk, is good because it fills you up and therefore you're less hungry, and so what is the what is the real advice there?
Yeah, look, when we look into what the Heart Foundation is recommending, they're still recommending for women, most for postmenopause women, to have low fat. The amount of calcium is usually very similar, and the calcium is what we're particularly interested in postmenopausal women, because the risk of osteoporosis, another positive thing associated with menopause, is that osteoporosis risk increases with a reduction in estrogen. So focusing on bone health is really important, but there's lower fat options of calcium. So some cheeses have less fat in them. Something like a natural yogurt is probably a better option than a hard cheese, which is going to have more saturated fat. And also there's some for women that are vegan and don't have dairy products. Also some nuts can be a good source. Most soy products are also fortified with calcium, and it's just checking the label for that, as well as tofu, tempeh, and also if you do eat fish, is sardines and other fish that has small bones in it is also a really good source of calcium.
Okay, fantastic. Esther, getting back to you, across, what do we know about how heart disease, or the risk of heart disease, or the manifestation of heart disease across different cultural groups, or people with different ethnic backgrounds?
Look, excellent question. And it's still an area we're learning a lot about, I think. We certainly know women experience heart disease differently. And there are certainly some reports that suggest that, for different cultural and ethnic backgrounds, different symptoms may predominate. I do want to sort of emphasize that we also know that, still classic symptoms are the most common symptoms across most populations that we study. But I think, going forward, research that, helps us better understand those different manifestations of heart disease is really useful, and will help us, work towards, improving outcomes for all our really diverse communities, and better understanding how they prioritise their symptoms and what symptoms are most important to them will be helpful too. But certainly also what we know across multiple, studies in multiple cultures is that, women from multiple ethnic backgrounds certainly, do deprioritise their symptoms, unfortunately, and do tend to present later to hospital or to health practitioners than men. So I think that seems to be a fairly universal theme in heart disease in women, unfortunately.
Fortunately. And while I have you, Esther, there's a question here about CAC scores. So how reliable are CAC scores, and can you explain what they are, to evaluate risk? This person says, if my score is 0, but I'm a diabetic, what does that actually mean?
Yeah, so look, coronary calcium scores are one of sort of our many array of testing that we can do to look at the heart. It's basically a score where they take a CT picture of your heart, and then they just look at, is there calcium? So are there bright white specks in the areas where the arteries should be? And this can be useful because as disease forms in the arteries, it does often develop calcium, but it's not perfect, I suppose, what I would say, because it doesn't look at the inside of the arteries. And so it is possible to have soft plaque, which doesn't have calcium in it yet, which is sort of can also be a risk factor for having a heart attack and might tell us that we're developing early disease that hasn't quite got there yet. And so, look, I think for, patients who are at risk of heart disease, particularly those who we think are high risk of heart disease, it's important for them to have discussions with their doctors about, is this the right test for me? Because there are circumstances in which, this is the perfect test or a great test that helps us make decisions. And there are other circumstances in which we might want to think about different tests so that, we can make the right decision for the individual patient.
Okay, thank you. And so, Amanda, we have a question here regarding what do women need to do to help with menopause? Just common things, a checklist. That's from Michelle.
So I think at the time of menopause, what you want to think about is, do you have symptoms? And certainly the most common ones are the hot flushes and night sweats. As I said, they affect about 80% of women, and about a third of those women would have severe symptoms. So there are other symptoms that women may experience, including vaginal dryness or urinary frequency or urinary changes, and another change about, sleep, poor sleep, women often describe brain fog, and a whole lot of other things about increased anxiety and depression at that time, which can also influence heart disease risk as well, anxiety or depression particularly. So I think number one is look at what symptoms are you experiencing. I think number two is your psychological health. And as Sam was talking about before, often for women at this time of life, there's lots of competing pressures on them. They're often busy in a career. They've got caring responsibilities. There's a number of things that are impacting them. There is this increased risk of depressed mood and also onset of depression. So I think psychological health, then I think heart health, which is what we're concentrating on today, and all the things that we've heard about today about looking after heart health, being proactive about lifestyle, so that if you are a smoker, it's a really good time to stop smoking. Look at the diet and exercise as Sam has discussed, making sure that you moderate your alcohol, moderate your alcohol intake. And then there's also the question of bone health. And I think that there is an increase. We haven't talked about bone health today particularly, but there is an increased risk of osteoporosis, so there's increased bone loss across the menopause transition with an increased risk of osteoporosis in later life. Almost about 1 in 2 women may potentially have an osteoporotic fracture, later on in life. So it's something that's very important. So as Sam was talking about, is optimizing calcium intake, exercising, particularly weight-bearing exercise for bone health. Aerobic exercise is more important for heart health, but weight-bearing exercise is important for bone health. So I think that and then obviously cancer screening. So Mammograms are freely available through the breast screen from the age of 50. Also remember to be up to date with your cervical smear tests, and also colon, bowel cancer screening as well. So those would be sort of the key things. That would be my checklist for any woman around the time of menopause.
Okay, great. Esther, I can tell you as a woman, getting close to 60, two things happen to you. You get lots of social media feeds around funeral plans, which is fun. And then also lots of advertising around very sophisticated cardiac monitoring tests, very invasive and very expensive tests. What's your view on that? Should we be taking these up? Should we be doing these, or are they not helpful?
I think it's probably a complicated question. I think that what I would say, or what I would recommend, is that overall we need to do the basic things well. And so that means getting people to know what their blood pressure is, and if the blood pressure is bad, control it, know what their cholesterol is and suppress that if it's elevated, and keep a good eye to make sure they're not developing diabetes and other things like that. Those simple, lifestyle things, if we could get every woman in Australia doing that around the age of 60, I think we'd go a long way to, to reducing heart disease in this population. Beyond that, I think that, while there can be some benefits of asymptomatic testing in certain situations, you do have to think about downstream effects and unnecessary testing, particularly if it's invasive testing. So I think that in that context, I think an individualized discussion with your doctor about whether you're actually in a situation where that would benefit you is important, rather than suggesting that every person in the population should undergo invasive testing, because we certainly know if we did that, we would do some good, but some harm as well.
And if women have a particularly strong heart disease history in their family, is there risk at menopause that much greater, or are they kind of leveled out by menopause? Is it kind of a level ground, playing field once you're post-menopause? We're all kind of high risk anyway.
Well, women catch up to men about 10 years post-menopause, so it takes a while for women's heart risk to catch up, and we sort of still feel that heart disease in women is premature if it's even up to 60. So we do give women quite a lot longer because of that fact. So I think in women who do have a particularly strong risk in the family, it's more important than for anyone else to be seen during that period, so that we can start preventative strategies early.
Yeah, great. Sam, there's a question here about reliable online sources of information around lifestyle, and there's a lot of lifestyle apps and things now. What would you recommend? What should people look out for? What's a good reliable source of information that you would recommend?
The Australasian Menopause Foundation have some really good resources. The Jean Hales Foundation has also got some really good resources on diet and weight. And the Heart Foundation is a really reliable source as well. Diabetes Australia also have some good resources related to heart as well. And also looking on the Dietitians Association website would be where I would start off.
Okay, so maybe those links we can send out when we send out the responses to the questions. So I'm going to throw a curly question at you all now, that without notice, as they say, and so I'm interested in your responses. Amanda, there's what you tell us to do as a clinician, but what do you actually do to keep your heart healthy in a post-menopause context?
So I have a family history of heart disease. I have been to see my GP at least once a year to have to have my, cardiovascular risk factors checked. So I have my diabetes screen, I have my cholesterol checked, they check my blood pressure for me. And then I try and I do exercise, even if it's just walking every day. I also like to garden, and I try and maintain as healthy a diet as I possibly can. I go out occasionally, but most of the time I'm trying to adhere to a predominantly fresh food, low fat diet, cooking with olive oil, as Sam said. We rarely have takeaway. And I suppose my guilty pleasure is cheese, really.
What sort of cheese? Full fat cheese? Are we talking saturated?
We're talking any cheese, really.
Okay. What about supplements? Honestly, what do you take? Do you take any supplements?
I take vitamin D because with my check with my GP, I was found to have a low vitamin D, so I take vitamin D. I don't take any other supplements. I'd be interested in Esther's comments about fish oil. Some of those, like fish oil, is often sort of talked about, etc. But I don't take any supplements at this stage.
All right. So Esther, I'm not quite sure your age. You do look a little quite young. So projecting yourself forward, what do you do now to protect your heart, but also when you do get to postmenopause age, what are you really going to focus on?
So, like Amanda, I don't have a family history of heart disease, so I'm lucky in that, although I do have a family history of high cholesterol. So for me, even though I've not quite reached the age where the government would say I can go and have a heart health check, I'm certainly very interested in knowing my blood pressure, knowing my cholesterol, and making sure that I'm on top of those things. Regular physical activity, and trying to exercise a little bit every day, and trying as much as I can, acknowledging that it can be hard for all of us, and all of us make the occasional unhealthy dietary choices, to eat a low processed diet with lots of vegetables. Like Amanda, my guilty pleasure is cheese. And when I was once much younger, I remember saying to my GP, I don't really want you to test my cholesterol because I'd have to stop eating cheese. And I don't want to do that.
It's good to know you have some guilty pleasure.
But no, I've grown up now and I know what my cholesterol is. So doing those things, I think, is really important. And then, projecting forward, I think, it's very important just to keep aware of all of those risk factors and make sure you're managing them as much as possible. I personally don't take any supplements at the moment.
I was going to say, what do you recommend any supplements? Do you recommend people not take supplements? Where are you at in that?
Look, I mean, obviously, quite a lot of my patients will take some form of mineral supplements. Magnesium is one of the most common ones, which from a heart perspective is fine. We actually quite like magnesium. Obviously, if people are vitamin D deficient, they should be supplemented appropriately. The fish oil story is interesting. Fish oil can have a beneficial effect on your cholesterol profile. There's no doubt about that. But the amount of fish oil you have to take to have that beneficial effect is enormous. So if we're actually trying to treat people's cholesterol profiles with fish oil, they'll often end up taking like 8 or 12 or more tablets a day. So I think the capacity of sort of low dose fish oil to influence your cholesterol profile in that way is a little bit less clear.
Okay, and yeah, we're kind of worried about fish now too, what else is in fish. So that's a bit of a concern. Just back to your magnesium, can you just elaborate on that? Why are you keen on magnesium, and what would be an indication for taking magnesium?
A lot of my patients take it for cramps, which is absolutely fine. But from a heart perspective, actually having good magnesium levels reduces your risk of having funny heart rhythms. I don't routinely supplement my patients. Most people maintain a completely normal magnesium level on their own without needing anything. But it is actually, one of the salts that we use a bit more liberally, perhaps, so people, particularly when they're in hospital.
Hey. Do you want to look at how much, what sort of dosage if people were taking magnesium, what's the usual dosage you would take?
It depends on the formulation, and certainly people who are taking it for cramps, it's often just one tablet or one scoop of the bioavailable magnesium a day. If we're using it to actually treat cardiac arrhythmias or things like that, the dosing is very different. So in that case, it's individualized depending on what the patient's needs are.
All right. So in the last 5 minutes, I'm going to just ask you all about, so we all believe, or we all understand there's a strong connection between how we manage stress in our lives and heart disease. And we certainly know, as you said, Amanda, as in a post-menopausal timeframe, we've got lots of stresses. We have our parents we're caring for. We still have, younger children. In my case, I've got grandchildren. So there's a lot going on. Just want to hear from the three of you, just maybe your 2 top tips, maybe around how you would recommend, people cope with stress. Your 2 top tips. So, Esther, I'll throw it to you first.
Oh, look, I think this is a really fascinating area because we're learning more and more about the heart-brain interface and how emotions play into heart disease and how stress plays into heart disease. And certainly for women, there are a couple of heart conditions, we haven't spoken about them today, that are much more common in women than men, and they tend to be precipitated by really profound emotional stress. So there really is this link that goes on there. I think, look, for me, obviously managing stress is a really difficult area, but I certainly encourage my patients to prioritize their physical health in terms of regular physical activity, taking time to themselves, prioritizing activities like meditation if that's useful for them, and if they are struggling or things are getting on top of them, to see their GP so that we can start working them towards a plan for support, so that we can do everything from our perspective as well to support and minimize stress. So
your message is manage it, acknowledge it and manage it.
I think acknowledge it and treat it as important.
Yeah. Okay, great. Amanda, your top tips?
So I'd start by acknowledge and managing it. But for managing it, so cognitive behavioral therapy, meditation, mindfulness has been shown to be helpful for managing stress, but also has been shown in clinical trials, certainly CBT, cognitive behavioral therapy, to help menopausal hot flushes, help mood and the sleep disturbance as well. There's also evidence that it can help in other settings, pain management as well. So I would think about that, and otherwise I pretty well echo what Esther said. My only other thing is learn to turn off your device. Have a time, try and set a time where you're not scrolling through Facebook, or you disconnect from the online world. I think can be.
I feel stressful just hearing you say that. Sam, sorry, I didn't throw to you before around how you would manage in menopause before, because I know you're so young, because you're just still having young children. But your top stress tips, because having 3 little ones that I know you have, how do you stay sane? How do you manage your stress?
Well, I think taking a bit of time for yourself is really important within your constraints. So having a little bit of kid-free time if you can manage it, even if it's just 10 minutes. And for me, it's yes, and I think social connection is another really important thing. So at the moment, I'm sort of in the thick of children, so connecting with other mothers and friends, and just having a laugh about what your kids have done, and managing work and life and children, and setting, and expectations, sort of giving in a bit to trying to take the pressure off and sort of just, giving into the chaos and, hoping that
Okay, giving into the chaos. I think that we'll take that as our what we should all remember from today. Give into the chaos. I also like in the thick of the children. So today we've been in the thick of the menopause, in the thick of the heart disease and the menopause phase of our lives. I want to sincerely thank the three of you for your time and your expertise today. So thank you very much, Esther, Amanda, and Samantha. Thank you to everyone that has joined us. I hope that it's been useful to you. As I said, we will send out written answers to our questions. If you have further questions, please don't hesitate to contact us. Otherwise, have a wonderful day, and thank you all very much.
You.